Hi, everybody. I just want to say thank you so much for joining. My name is Sarah Ashton. I'm going to get us started in a couple of minutes, but we see that still a few joining, so we'll give it a couple more minutes before we really get our session started. But just wanted to acknowledge you're in the right place, and please bear with us while we give a chance for others to join. All right. Just looking at the time, it's just about 5 after 7. So just want to thank everybody for taking the time tonight to join us for our town hall to talk about the upcoming changes to breast cancer screening. My name is Sarah Ashton. I am the Regional Manager for Cancer Screening and Prevention and the Indigenous Cancer Program. So I'm really thrilled to welcome you all here tonight to learn about changes to the Ontario Breast Screening Program, or OBSP. I'll give a little bit of background information and then we will be handing it over to our speakers for tonight. So a couple of housekeeping items. In this setup through Microsoft Teams, all of our audience has been muted, so we can't hear you if you have a question, but we do invite you to put your questions in the Q&A box at the top of your screen. If you type in your questions, we'll be watching for those and we will ask them throughout the evening. And we certainly have time at the end of the evening for questions. This session is being recorded, just so you're aware, but we cannot see you and we cannot hear you, but the information is going to be recorded. So if you want to share this information with anybody in your friends, your family, please direct them to our website where we will have this link posted. We do have prizes for tonight, and we encourage you to put any questions in the chat, and we'll be looking to see who signed in, and from there we will be selecting winners, and they will be contacted tomorrow through email. And if you have any questions about this presentation or anything else related to cancer screening and prevention, our email address is there on the screen. And we also encourage you to visit our social media on Facebook, Instagram, LinkedIn, for updates that we share throughout the year, all year round, and also our website. We encourage you to have a look at our website for more information. So I'll just give a quick heads up. We've had a little bit of a tech issue in the background. So if at some point there is a bit of a blip or a cutout of the meeting, please hold tight and we'll get a new link out to you. But I just want to give that quick heads up. I think we're okay going forward, but just in case, know that there's a plan to get you back on, and we'll continue our presentation. So I'll give a little background about the Central East Regional Cancer Program. So the Central East, so our program, we are responsible for the quality and delivery of cancer services for the residents that in the Central East, which is the map you see on your left. So that includes people who live in Haliburton, Kawartha Lakes, Peterborough, Trent Hills, Northumberland, Durham Region, and Scarborough, who is our target audience for tonight. We work with a number of partners and organizations and hospitals listed here on the screen to ensure that we are giving high quality and timely cancer services. Screen. I've mentioned a couple of times our website. This is a great place to go for up-to-date information about our 4 cancer screening programs. Tonight we're focusing on the breast screening program, but we do encourage everyone to go to our website listed there to get up-to-date information about screening, to find locations for screening, and a lot of common questions that people have about screening, including how to do and participate in cancer screening without a family doctor or primary care provider. So just wanted to highlight that. I am going to now switch it over. I want to take a moment to acknowledge that we have 2 patients who have joined us this evening to share their stories, Jenny and Karen, and I want to thank them for taking time out of their evening to share their stories. And we'll start with Jenny's story, and then after Jenny, we'll be handing it over to Dr. Rebecca Ray. So thank you very much, and I will hand it over to Jenny.
Well, thank you for having me. It's a pleasure to be able to speak on my experience as having breast cancer as a young woman. You know, in my journey, this started in May of 2023 for me, and that's when I found my breast lump. I had just turned 42 years old. And it's amazing how, when I look back in hindsight with, these guidelines and how things would have been different for me if I was being screened at 40, how the trajectory of my disease would have maybe played out, if things were a little different for me. But it's amazing to be here. Unfortunately, cancer doesn't really care how old you are, and that's something I'm starting to see as myself. I'm a mom. I'm a college professor. I'm a busy person, and it does not discriminate, and it doesn't matter. Studies are showing that younger and younger people, women and men, are being diagnosed with breast cancer. And, the previous guidelines just did not support our most positive disease outcomes in the past. So now that our guidelines have changed, I think that's going to change many people's stories, hopefully, in their journey with breast cancer in the future. So, but yes, I was a young person being diagnosed. And I'm still going through some treatment. I'm through the hard, more active treatments, but I'm still on many medications, and going through my breast cancer journey. It was so symptom driven because I had no screening. We kind of found it a little bit late. So, and that's a true common story that we find in young people that are diagnosed with breast cancer, is that because of the age and the onset, on how things kind of present with disease symptoms, we're finding that our survival outcomes and our actual true health outcomes are the poorest. Our younger subset of patients that have breast cancer diagnoses. So because we're not being screened. Well, I wasn't screened at 40. And my doctors are pretty certain that if I was being screened at 40, we would have caught this earlier in an early stage so that, my outcomes would be a little different. But I do have stage 3B invasive ductal carcinoma of the left breast, and I'm currently undergoing some treatments, but I'm through the harder stuff. So I'm hopefully, going to continue in my advocacy efforts and be able to speak in events such as this.
Thank you very much, Jenny. It's so impactful actually having a patient be able to share a story like that. And we really appreciate you, actually. I so appreciate you coming and sharing that story. I know it's fresh. It's fresh, right? You're still going through treatment.
It's fresh.
So,
Yep, it's
yeah.
pretty fresh. And I have some more surgeries coming up. So um, and I really wanted to say, like my primary care physician, she was, and she still is such a huge proponent in really pushing women to get screened. But again, she was held back by the old guidelines, right? So unfortunately, I was not, on her radar. And she even says to this day that, had I been on her radar, my story would be a little different, right? So. But nonetheless, I really just wanted to be here to share my story because I do sincerely believe that my quality of life and my survival outcomes and all of that would be very different if I was screened 2 years ago. And I'm hoping just to reach, at least one woman or man in order to get them to take advantage of these new screening guidelines and to self-refer, go get your mammogram and go get some screening done.
Thank you. Thank you so much, Jenny.
Welcome.
That's a great segue into the next part of the presentation, or the first part of the presentation. So we're going to talk about the cancer journey with a real focus on, so the cancer journey for women like Jenny is moving beyond that screening stage, right? So Jenny didn't have the benefit of being screened early the way that we do since October the 8th. Those of us who are in their 40s, those women who are in their 40s can now reach out and be screened. And so her journey, unfortunately, went beyond screening. But what we focus on with screening, with cancer screening, is actually keeping people in the prevention and screening bit, right? So if we can actually prevent you from moving into diagnosis and treatment through the screening, then we can really augment what the cancer journey looks like for our patients. So why is screening important? So Jenny actually provided a really nice voice and a story for why screening is important. So through cancer screening, we can detect cancers early when cancers are small and they're easier to treat. Unfortunately, particularly with breast cancer, often by the time that we can feel a cancer, it's typically the size of a marble. I wish I had one to show you, but it's at least the size of a marble, or maybe even more like a boulder, if you ever played marbles when you were young. And if we do screening, we're detecting cancer much earlier when it's smaller than a pea or a really tiny little pebble. And the other thing is that cancers, when we detect them when they're that small, are easier to treat. And often the treatment is less invasive or less intensive when we detect cancers early. So in Ontario, we have 4 organized screening programs currently. Tonight, we're going to focus on breast cancer screening, but we do have an organized screening program for cervical cancer, for colon cancer, and for lung cancer. So the Ontario Breast Cancer Screening Program is a provincial, so it's province-wide. It's an organized program to screen for breast cancer. The breast cancer screening program was launched in 1990, and the reason we're here speaking to you tonight is that we continue to evolve the program to grow it when we get new evidence or new technology or new science to support change. So that is what has happened as of October 8th. We have grown the program and changed the program. And so we're here to share that information with you tonight. The breast cancer screening program is designed to help people get screened and to organize that screening for you. So breast cancer screening actually, the benefits of having an organized screening program are that when you'll be invited to the program. So when you turn a certain age, you'll actually get a letter in the mail inviting you to join the screening program. After you've had a screening test, if you're in an organized screening program like the Ontario Breast Cancer Screening Program, you'll receive another letter in the mail telling you the results, sharing the results with you. And if there's an abnormal result, that will be included in the letter. So, in my case, it might say, hi, Becky, thank you for being screened in the Ontario Breast Cancer Screening Program. Your screening results are normal. Your mammogram is normal. Or it might say your screening results are abnormal and you need to follow up with your primary care provider to review this. So it really helps to prevent things from falling through the cracks. And we know breast cancer is incredibly common. So 1 in 9 women currently living in Ontario will receive a breast cancer diagnosis at some point in their lifetime. So that's an awful lot of people. We want to reduce that number if possible. And certainly we want to try to change the cancer journey for patients by finding cancer earlier when it's more treatable. And that's the reason that we screen. So what does screening look like in Ontario? I think the next slide is a picture of a mammogram. Oh, why is it needed? Okay, so it's a little bit more. So I apologize. I was one step ahead of myself. I think a lot of this already we went through. So we do need to screen because breast cancer is common. So 1 in 9 women will get a breast cancer diagnosis at some point in their lifetime. And breast cancer is a cancer that we can't necessarily prevent through living a really polished lifestyle, with lifestyle changes. So we still encourage women to be physically active and eat more fruit and avoid smoking and maintain a healthy weight and not drink alcohol or drink alcohol in very low quantities because there is an association between for example, alcohol and smoking and cancers. But because we can't prevent all breast cancers, we screen so that we can detect cancer. Because as Jenny said, cancer doesn't care how old you are. And often cancer just, it picks and chooses, and we don't necessarily know who it's going to pick and choose. So we want to screen everybody so that we can detect it early. Currently in Ontario, only 61.2% of women who are eligible for breast cancer screening are up to date on their breast cancer screening. So only 61% of women who are eligible for a mammogram have actually had them. So that means that there's almost 40% of women who are eligible for breast cancer screening who haven't been screened. And that's what we want to change. We really want to increase awareness, help people to understand the importance of breast cancer screening, how to get screened so that we can really start to make a difference in the cancer journey for patients. So some tools that you can use. These are really helpful tools for patients to explore their risk of cancer. And this is one of them. This is called My Cancer IQ. And My Cancer IQ is a cancer assessment tool that's available actually for 7 different cancers, I believe, if you go on to the Ontario Health website. I think we have a link to it through the Central East Regional Cancer Program website as well. But I do encourage people to go and do this tool. It will helps to actually reinforce the positive choices that you're making in your life. Helps to give you a few tips on what you could do to help to reduce risks of cancer. But it gives you an idea of what your own personal risk is. And sometimes that's just enough to help just push people to get their cancer screening updated. So how do we screen? We screen with a mammogram, which is essentially an X-ray of the breast that helps to look for abnormal changes in the breast, and again is able to detect these abnormal changes in the breast tissue when they're too small for us to actually feel by doing a breast exam. And you can book your mammogram. You can self-refer. So you don't have to have a nurse practitioner or a physician to refer you for a mammogram. You can actually book your own mammogram if you go to ontariohealth.ca /breast screening locations. It will help to show you the location closest to you, and then you will call that location. So you put in your postal code, and this is a really great tool. I tried it myself the other day. I entered my postal code and it shows the closest mammogram site to me and what the wait time is. And then it'll actually, if you scroll down the list, it shows you alternate choices and the typical wait times at each of those sites. So maybe you don't work where you live and it's more convenient for you to have a mammogram on your lunch hour at work. You can actually put in your work postal code and search for a mammogram site that way, and then connect and self-refer for that. So please share this information too with your friends and your colleagues and your family so that we can spread the word. And now I'm very pleased to introduce Karen. Karen Smythe. Karen, thank you for being with us tonight to share your story.
Thank you. I'm honored to be here in many ways. First of all, I wanted to say thank you to Jenny for sharing her story. My story is quite different. When I turned 40, my family doctor told me that every 2 years from 40 on, I was going to have a mammogram. So I did. And everything was fine until I turned 49. And one morning I was in the shower and I felt this, it wasn't a lump, it felt like an orange underneath my skin. So I went directly to my family doctor, and probably 2 or 3 weeks worth of testing. I had 2 mammograms, a biopsy, an ultrasound, a CAT scan, and my breast cancer was not found until an MRI was done. And between the date I was told I had breast cancer and my surgery date was 4 weeks. So from there, I had chemotherapy for 6 months and 25 rounds of radiation. And I had a mastectomy on my left breast. And that was 5 years ago. So I guess I'm a success story now. But yeah, when I was diagnosed, both of my kids were just starting university, and it certainly is an eye-opener to what you need to do, what you needed to do. What I needed to do was take care of myself first. And unfortunately, as women, as mothers, we most of the time the kids come first, and we need to kind of change up that mindset, because if we're not here to take care of them, then that we are important. We are very important. So I think that's all. And I was told by the surgeon, because she actually did 2 MRIs. Initially, I was told I was going to have a lumpectomy, and then she wasn't pleased with what she saw, so she did a second MRI and said I needed to have a mastectomy. And she also told me that women with dense breast tissue, it's more difficult to see on a mammogram sometimes. So that's why they did the MRI in the end, and thank goodness they found what they found. So, but that's all I have to say, I think, unless somebody has any questions for me.
Thank you so much, Karen, for sharing your story. I know it's not easy to come out and talk in front of others, but I just, we're so appreciative of you taking the time today to tell your story. So thank you. Thank you very much. Um, I am going to now hand it over to Dr. Rola Shaheen, and she's going to talk to us a bit more about the changes in the guidelines around the OBSP and the screening between the ages of 40 and 49. So thank you, Dr. Shaheen, for joining us tonight.
Thank you so much, Sarah. And I'm very touched and emotional about the presentations of both Karen and Jenny. I really appreciate having you with us today, because only the patient's voice actually will get things moving and changed, and encourage other women to go forward and take care of themselves and get screened and try their best to catch it as early as possible. So I really appreciate your presence, your courage, and sharing your journey. You guys are doing amazing, and I wish you all the best. So thank you. I'm going to touch actually and on some of the points you mentioned, but let me start by highlighting again the change that we had as of October 8th. We're very excited about the fact that now the OBSP, the Ontario Breast Screening Program, has expanded to include eligible population between 40 to 49. Having said that, in Ontario, women used to, just like Karen's case, like they used to get screened. However, they needed a referral from a physician or nurse practitioner to get screened. And there's lots of conflicting information for women between 40 to 49 at that time. And we felt that's created an inequity. Therefore, the OBSP moved forward with that expansion. And now women don't need to have that referral, and they can refer themselves. Next slide, please. And the fact that we had women actually screened in Ontario between that age gave us the opportunity to draw our own conclusions from within Ontario. And I'm going to talk about the rationale shortly. But I just want to share with you who's eligible for screening, because the concept of screening is different than the concept of diagnostic, meaning that women should be asymptomatic. They like basically don't have breast cancer symptoms. Like as you noted, both Jenny and Karen had actually symptoms when they presented, even though that Karen had gone through screening between the age of 40 to 49 when she discovered her lump. Also, they should have a prior personal history of breast cancer, no history of mastectomy, which means removal of the breast surgically, and basically if they didn't have a screening mammogram within 11 months. Also, if trans feminine, that they have used feminizing hormones for at least 5 years in a row. Another thing is that, which is probably considered some new information to women, is the fact that they can still be screened during pregnancy and during lactation, especially 3 months after delivery. Because let's say if they are due for screening and they happen to be pregnant or lactating, we don't want them to miss the opportunity to get that screen, because it's very low dose. It's safe for the baby. It is challenging though, given the changes with the breast, but radiologists are getting better at with experience, they're getting better at reading the mammograms. The more volumes we see, the more different types of patients we see, we get better with that. Also, women with breast implants, but this has been, at least for the past 2 to 3 years, women with breast implants are also eligible to be part of the screening through OBSP. Next slide, please. So 13% of women between 40 to 49 will have breast cancer. So that's a big percentage when we compare to the relatively to the rest of the age group. So the highest percentage, obviously, it's when women get older. It's one of the risk factors between 60 to 69, which is 28%. But 13% is a large percentage relatively, and that's why we feel that women will have more equitable access by having self-referral to get screened for breast cancer. Also, research has proved that there is the benefit to harms ratio is also higher in that age group. Plus that those women that got the opportunity to be screened between 40 to 49, their cancers were discovered in earlier stage, and basically they will have better outcome. Lastly, women who did not get screened in that age group in Ontario were found to have basically there's some inequities because the specific communities did not have access and certain neighborhoods did not have access to that kind of screening. Therefore, being part of a bigger umbrella of OBSP with organized screening where women get invited and they get their results in an organized fashion and somebody will work with them to close the loop on their screening outcomes is very important. Next slide, please. There are pros and cons for screening in general, but when it comes to screening for breast cancer, as we know, Rebecca actually touched on this, we cannot really prevent breast cancer. That's why screening is crucial in the case of breast cancer, because the earlier we detect it, the better is the outcome. The smaller is the lesion, the better cosmetic, even with surgery, in terms of if the woman prefers to have lumpectomy versus mastectomy, the aggressiveness of the treatment, depending obviously on the type of cancer, because breast cancer is not one disease. It's actually a group of different diseases and different pathologies that happen in the breast. So, but we all agree that the earlier the detection, the better is the outcome, and the less the chance that the woman would die from breast cancer. But there are some potential harms. We create sometimes anxiety for women when we call them back from screening when there's really nothing as cancer. Like probably it's just overlap breast parenchyma, really something benign like a fibroadenoma or just a cyst. So, and sometimes we even have to do a biopsy, and this turns out to be also a negative biopsy, meaning that it's benign. So that's one of the harms. And the concept of overdiagnosis, they claim that there might be some cancers or some findings that are really not going to cause the death of the woman on the long run. Next, please. We talked about, I think, Karen, it was you who mentioned breast density. So breast density, it's basically the amount of parenchymal breast tissue that would show on the mammogram. The mammogram is really, as you can see here, is black and white. And the white material that you can see on the mammogram is actually the breast parenchyma. Unfortunately, cancer would look like also most of the time in that whitish density. And sometimes it's hard to differentiate it from the normal parenchyma when the breast is very dense. That's why we divide the breast in 4 categories. A, when it's almost completely fatty, when there is really not much dense breast parenchyma, and it's mostly grayish, as you can see here, on category A. Category B, when we call it scatters fibroglandular densities. And category C, it's heterogeneously dense. And the last one is category D, which is really kind of, we call it the nightmare of the radiologist, because breast cancer can be hidden in there, and mammography is not as efficient as like when the woman has a category A. And that's why also some of the changes that happened and we're not touching on details on it tonight, but it is coming that there will be supplemental screening for women with category D, where they can have an ultrasound and or breast MRI to help with detecting cancer. Especially that now you will see in your mammography report that you can access, you will be told what type of breast density you have so that you can have the awareness of what are the next steps that you can discuss with your primary care physician. Next slide, please. A little bit about the symptoms of breast cancer, because as we said, if the woman is experiencing symptoms, then she's not eligible for screening. But it's even more important once she discovers any of these symptoms or signs that she presents herself to her family doctor or nurse practitioner to get further testing. And these are like the most common one usually is a breast lump, nipple discharge, thickening, axillary lump, as well, and some changes in the skin. And we always say in a good screening program where women in an organized screening program, like doing the self-breast examination is not really necessary, but what's important is that the woman should know how her breast feels like. They know what their normal breast feels like because they can know when there is an abnormality or change in the breast because some women are lumpy, pumpy all the time. So if they noticed a change in that kind of sensation or feeling, that's when they need to present to their doctors in order to have a diagnostic workup, which can be mammogram, ultrasound, and MRI. And as in Karen's case, sometimes mammogram and ultrasound can't really find the cancer, and we call it mammo occult. So that's why they move to the MRI, where MRI is very sensitive and specific, and it can actually direct where the biopsy can be done. Next slide. Yeah, I think we're coming to the end, and we're more than happy to take your questions. And again, thank you so much for the organizers, for my wonderful team, for Rebecca, and for the wonderful patients who shared their experiences. I'm honored.
Great. Thank you so much. This was a great presentation. I echo thanks and gratitude to Jenny and Karen for sharing their stories today. It's incredible what your experiences can add to these conversations, and it is just something we can't do without you. So thank you so, so much. Caitlin from our team has been receiving some questions during the registration process. So I'm going to hand it over to Caitlin to ask her questions and let Dr. Ray and Dr. Shaheen provide a little extra information.
Perfect, thank you. So the first question is for Dr. Ray. Do family physicians still do breast exams during a physical?
So that's a great question. And the answer I think is well, I know the answer is it depends, right? It depends on your family doctor. So the guidelines no longer recommend routine breast exams during a physical. So you won't necessarily have a breast exam, but some physicians will still perform a breast exam as part of a physical exam. But more importantly, if you have a symptom. So I imagine in Karen's case, and in Jenny's case, actually, when they presented to their primary care physician with their changes that they experienced, that an examination was performed so that the physician could get an idea of what they were feeling and what the experience was with that, and to order the correct testing. So it might not be part of routine screening any longer, but it certainly is part of diagnosis if you do have a symptom.
Perfect, thank you. For Dr. Shaheen, should menopausal women undergoing hormone replacement therapy be screened more often?
I don't think so. I mean, basically now, as we know, the hormone replacement therapy is back in the picture, and you'll see many primary care physicians actually, if the woman asks for it, they will discuss the safety, especially if they they don't have a strong family history. Women would be taking it safely, and there are studies now that have proven the benefit of taking care of the menopause symptoms, and therefore it's good to ask about it. Like we like to know about it, and the reason why we want to know about it, because hormones can change that breast density that I talked about. And it's nice to know that if we see a change, that, yeah, she's on hormone replacement therapy. I always ask that question. For example, if I see a postmenopausal woman with new cysts, and that can be explained by having those hormone replacement therapy. But the screening should be based on the family history and the breast density and the radiologist's discretion. So basically, the same intervals that the OBSP has recommended.
Perfect, thank you. A question for Jenny, if you're okay with this. What piece of advice would you give to women listening?
Well, I think it kind of echoes what Karen said about, putting yourself first in that line, because I do share that same feeling. I'm a young mother, I'm a young professional, and I think I put my health on the back burner where it really should have been in the forefront because if I'm not here, then what happens to my daughters? They need a mother, I need to make sure that I'm here to be with my family. So I think the biggest piece of advice would be to check your breast regularly, but definitely put your health first. Go get, self-refer to your first mammogram if you're 40 and above. I mean, what a gift that is to have the opportunity. I really wish, I mean, all of my friends, all of my family members, I'm hounding everyone self-refer because, of my particular case, I would have been sitting in a different journey right now if I had been screened at 40. So yeah, go self-refer, and don't be afraid if you feel any changes in your breast tissue. Go see your primary care physician because you may not pick up a subtlety that they understand that might be actually something that could be, pathological in nature, right? So, don't ignore it and don't put it off. I know sometimes I have a lot of friends that say, "Oh, I have lumpy breasts," or, "Yeah, I get this thing once in a while with hormones." If you're not sure, you need to go to your primary care physician, and then they can direct you if you need further screening or if you need other imaging. In my case, I actually fell in that category D density as well. So unfortunately, with my cancer, they did see the invasive ductal carcinoma, which was about 5 centimeter mass. It was quite big. But I had a whole bunch of ductal carcinoma in situ, which is cancer that hadn't left the ducts of my breast, but there was 8 centimeters of it that was hidden in my mammogram because of the density of my breast tissue. So I didn't know any of this until I got my pathology back, how extensive the cancer was, in my breast. And it was also in my lymph nodes. I had 5 positive lymph nodes as well. So it was a big surgery. I had a mastectomy. I had a huge clearance out of my armpit. They took all of my lymph nodes. So this is a serious thing, that we can screen for it now, and it's a gift. It is something that we should jump on. So self-refer. Go get your first mammogram, and most of the time nothing comes out of them, right? So don't be afraid to get it. It's very rare that something would show up on a mammogram. But if it does, then you're lucky. You're one of the lucky ones to get that early diagnosis. And it's that early diagnosis that is so key because it saves people's lives, right? If we're not having that early diagnosis, then we catch it too late. And, thank goodness for me, it's looking like it has not spread anywhere. And I'm on lots of medications to prevent it from moving. But I went through a lot of chemotherapy and a lot of radiation to control the disease. So I'm at that point now where I'm in the maintenance phase, right? They're not calling me cured, but they really want to. The curative intent is there. So, but with early screening, definitely my treatment plan would have been different. My quality of life would have been different. I have some heart damage from chemo. I actually currently have a blood clot in my leg. from treatments that I'm on, that I'm being treated now with heavy duty blood thinners. So, my life has changed. It has changed forever. And, with simple screening that may have changed my life would have been something that would have been a gift for me. So take it, self-refer, just go do it.
That's amazing. Thank you so much for that.
Welcome.
Hard act to follow. So, Dr. Ray, so why does the OBSP program stop at the age of 74? And how does the program help women 75 and over?
That's a great question. So the organized screening program ends at age 74, but it doesn't mean that you can't have a mammogram if you're over age 74. So screening doesn't have to stop at 74, but the organized structured screening program stops at age 74. And the reason for that is that health is changing. Like people at the age of 74 and 75 might have very different health at that point. And so having mammogram screening might not be right for all women at age 75, for example, but it might be very right for many women at age 75. So as a family doctor in my practice, I routinely talk to women about that. So, as they're approaching their mid 70s and coming to the end of screening, I'll say, just because you're turning, 75 next year and you'll be phased out of the screening program doesn't mean I don't think mammograms are important for you. So I want to make sure that we talk about that. And that way it's in their mind. So when they turn, when they're 75 or 76, if I haven't spoken to them about it, they'll bring that up so that we will have that conversation and we can order the screening if it's appropriate. We certainly know that the rate of breast cancer, the breast cancer incidence in women in their 70s is actually quite it's high comparatively of the age groups. So women in their 70s, I think, and Rolla can correct me if I'm wrong, I think it's about 23%, maybe a little bit less, maybe it's a little bit less than that in the 70s. Yeah, 23% in the 50s and the 60s, and then it's on its way down in the 70s, but still it's significant. So screening might be appropriate at that age.
Thank you. Dr. Shaheen, I am small chested. Will there be enough breast for screening with a mammogram?
That question from a woman or a man?
It was from a woman.
I know. Well, you know what? We try our best, and we have wonderful techs. They're trained to deal with those challenging situation, whether it's a large breast or a small breast. Even men, which basically, technically, really, we have very, very small breasts, but the machines will be able to comfortably actually scan those breasts. Give it a try, and it's worth it. And the tech would tell you if it's not a proper test or not. Sometimes they put a note. We do have some women actually today. I was feeling like women with some disabilities, because you have to, as you know, if you've had your mammograms, you have to pose in certain positions and you have to hold like a few seconds there, or like 40 seconds to be accurate. It's for some certain disabilities, it's really hard. So we do consider that in our reports, and we mentioned the limitations. But I think a small breast is not a barrier for a mammogram. Just to be clear.
Perfect, thank you. So there's one in the chat. Who gets the results for a self-referral? I'm not sure. Dr. Shaheen, do you want to take that one?
Sure, because I'm very excited about the self-referral part. So the self-referral means even if you have a family doctor, you can still self-refer, correct? Like we do get women calling in to get self-referral. So we'll ask the question, do you have a family doctor? If they have a family doctor, the results will go to their family doctor. If not, which as we know, post-COVID, this problem has evolved, that women, or we don't have enough family doctors or primary care physicians. But the good news, and that's the beauty to be within a national screening program, OBSP has designated champions, like physician champions, for each OBSP center, whether a nurse practitioner or a physician that would be responsible for handling these type of results. So depending on which center that woman has been screened at, the results will be taken care of by that designated physician for that OBSP center to take it from there. Actually, I think only when it's abnormal, correct? Like if it's normal, like she will receive a letter from the program. But if it's abnormal, she's still, like, we want to make sure she's not falling between the cracks, and that designated physician will take care of it, just to be clear. And I see Shannon approving what I'm saying.
Perfect, thank you. Is Karen still? I don't see her, but there is a question.
Karen is still there.
Karen's still there?
I'm here.
Perfect.
Yes.
So there was a question saying that you mentioned that you have sons in university. How did you tell them the news, and how did they take it with your diagnosis?
Oh, I have a daughter and a son, and they actually got back from university the day after I was told. So I only had 24 hours to prepare myself, and I think they were shocked, of course. They're, but they were very good throughout the process, and I'm so proud of both of them, and I don't know, life is good. There's happiness at the end of the rainbow. So
That's perfect. Thank you. Let's see. So this is for both Dr. Shaheen and Dr. Ray. What are some common misconceptions about breast cancer?
You go ahead, Dr. Shaheen.
Having worked in the Middle East and working with equity deserving communities in general, some of the misconceptions would be like breast cancer can be contagious, and breast cancer is not affecting younger women. It's only the disease of the older women. All these are wrong information. That breast lumps in younger women are not worrisome. Probably this is correct. That most of the time they're going to be benign, even in older women, but need to be checked regardless of the age. One important thing that Jenny highlighted: cancer doesn't, differentiate. Yes, it's a risk factor, women getting older, but when there is a symptom or sign, we need to act upon it. These are probably the most common things I've heard of, and I try to correct for women and just encourage them to raise their awareness and make sure that they come forward, especially if they are symptomatic. Becca, what would be yours? I'm interested to see from clinical point of view.
Actually, mine was relates to the question that I already had, actually, was that I'm too old to get breast cancer or I'm too young to get breast cancer. So I think those are probably the two biggest myths or misconceptions that I hear in my practice day to day. So, and that's exactly why I encourage women over the age of 74, if they're healthy and well and living a full life, to consider continuing screening with mammogram as long as they're well. And then young women too. So like Karen's family doctor, I have been offering screening to my patients outside of the Ontario Breast Cancer Screening Program starting at age 40, because I do know that breast cancer does affect women, and breast cancer doesn't discriminate based on the age. And I really loved Karen's message as well, about the importance of taking care of ourselves, right? So, I think that's another, misconception is we just think we're too busy or it's not going to affect us. But if we don't take care of our own wellness, then we might be taking care of our own illness. And so let's choose wellness. And thank you to Karen and Jenny. I'm going to go and get my own mammogram signed up. I'm going to self-refer in the morning.
Love
So thank you.
Can I add one more thing, just to put a plug for something? Caitlin, is that okay?
Of course.
So also breast pain. I just want to say that breast pain is very, 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 very common. Literally almost, I would say maybe 99% of women experience breast pain or unusual breast pain in their lifetime. But only breast pain that's not related, if you're premenopausal, that's not related to your menstrual cycle, is worth bringing forward to your family doctors. We see a lot of referrals and a lot of anxious women coming in having global breast pain, and really, I'm talking as a breast imager. Really, there's no diagnostic role at this point, and some reassurance and discussion between the woman and their primary care physician is very important at this point. And if the woman is postmenopausal and she has new sharp pain, this probably is worth bringing forward to the primary care physician, and based on their assessment, they can decide to refer the woman for either diagnostic or maybe sending her back to screening if she has missed some of the cycles for that.
Perfect. Thank you. I think we might have time for, I'm going to try and squeeze in 2 more. Is it correct that breastfeeding women may have higher rates of false positive findings of breast cancer?
I would say yes, just based on the changes of the breast, correct? Because I always say a previous mammogram is the best friend for the radiologist. And given that the breast changes that happens during the lactation and pregnancy will actually make us feel as if we're looking at a totally new mammogram, even if there is a previous. And that's why some changes may be called back, and we need to look at the symptoms, correct? Like depending on the setting, if it's easier if it's diagnostic because the woman can guide us towards where the symptoms are. If it's a lump, if it's just a milk duct that's dilated, whether it's a mass that's worth biopsying or following up, we will see some false positive, but we try to avoid biopsies as much as possible if the lesion looks benign or lactational changes, I would say.
I think that's great. If someone doesn't have OHIP, could they access this OBSP expansion?
100%. Yes. So you don't need to have OHIP to be screened for breast cancer. So you can still get yourself screened and have a mammogram.
Amazing. And we have 2 minutes, so that means 2 more. There was another one in the chat. If someone is using a vaginal estrogen cream, does this cause more sensitivity that doctors should advise on?
Sorry, sensitivity of what?
I'm not sure if that means like during the mammogram, with the increased estrogen.
Or maybe they're referring to this as being considered as a hormone replacement therapy, probably. Well, we ask about that too when we see a cyst. Again, in a postmenopausal woman, let's say she's 65 and showing up a small nodule on the mammogram, and then this turned out to be a cyst. And one of the things that we see that has changed is that a vaginal estrogen has been, or a patch has been used. And this will reassure me, instead of biopsying it, I would do a follow-up, you know what I mean? Rather than jumping at doing something aggressive. I hope that's what the question means, because sensitivity of the mammogram is very relative. Some women can tolerate it really well and some don't.
Perfect. And then we'll just wrap up with one more question for Dr. Ray. How do I have a conversation with my family doctor about whether I should be getting a mammogram. So going back to those benefits versus harms.
That's great. So it's actually really important if you have questions still to talk to your family doctor or your nurse practitioner about, what are the benefits. So I hope that everyone leaving here tonight understands the benefits of having breast cancer screening and won't really have any, I hope that we don't leave you with any questions about the benefits of having breast cancer screenings. But certainly talking to your primary care provider about potential, risks with having screening, or if you're worried about having screening, or if you're worried about, is it painful or is it right for me? That's when you should have a conversation with your primary care provider so that you can feel confident that you're making the right choice, the choice that feels right for you at this time. So you can choose whether to have your mammogram now or whether to not have it now, right? You don't have to choose whether or not you want to screen ever in your life. You're just going to choose, are you going to have your breast cancer screening now or not now, is really the choice.
Great. Thank you so much. That brings us to the end of this evening. I just want to highlight a couple of things for anyone that is on the call, or if you know someone who does not have a primary care provider and you think they have questions. 811 is a great resource if you want to talk about any questions you have about breast screening or any other cancer screening. It's a fabulous resource, so we encourage you to look that up. I want to draw attention earlier in the chat. Caitlin put in some links for you to check out. So the My Cancer IQ and just a link to more about breast cancer screening on our website. I'd like to say a thank you to the Scarborough Centre for Healthy Communities for helping to promote today and to share information about our town hall, and certainly for connecting us with Jenny and Karen for tonight to participate in this. So we're very grateful for that partnership. And of course, a great big thank you to the Scarborough OHT for their help and in their partnership as well, and for our speakers tonight. So a big thank you. Thank you to Dr. Ray and Dr. Shaheen, to Jenny and to Karen. And we really look forward to coming back another time with some additional information. And if you have any questions, please reach out to our email that we shared earlier. We'd be happy to respond. So thank you to everybody for taking time tonight to join us. Thank you.
Thank you. Good night.
Karen, thank you so much for speaking tonight, and Jenny.
My pleasure.
Of
Yes.
course.
It
There's nothing more important.
Yeah, I agree with that.
It's so I'm fairly new to the regional team, so this was the first time having like patient direct stories.